So warm welcome to all the attendees. We are starting with the webinar, and it is a very interesting webinar this time because of the passion of Dr. Ghousia madam to treat certain special pediatric cases. It is not easy. It requires a lot of dedication and not just the skill. It requires a certain temperament to go ahead and treat such children. So that is awesome, isn't it? So madam will definitely deliberate on various issues related to treating such aspects, how to recognize the signs and symptoms, and what are the tricks of the trade, as they say, to manage the such cases much better. So greetings from Group Pharmaceuticals, and we are happy to partner with Dr. Ghousia madam for this event. We are all aware that the COVID-19 situation is slightly better, but then the third wave danger is always there. Let us remember that when we talk, at least 2.5 microscopic saliva droplets per word are uttered, and all these can carry the germs. And these microscopic viral particles, they enter either into the respiratory tract or into the oral cavity. And there the ACE2 receptors are sitting there for trapping this COVID-19 SARS-CoV-2 virus. So with the help of the spike protein, this SARS-CoV-2 virus will lodge onto the ACE2 receptor and slowly get into the host cell, and replication starts. So that is when the infection sets in. And you can see the ACE2 receptors are spread across the nose, the tongue, the oral mucosa, the heart, the lungs, and even the gastrointestinal tract. So this is why the danger is there for the management of COVID-19. It's a great challenge. And this time when the third wave comes in, we should look out for COVID-19 and whether it's going to cause bother to the children. And yes, during the lockdown, children are having an unhealthy routine. There's a lot of social isolation, and this is making them vulnerable to even the mental health issues. Yes, the children with pre-existing mental and physical disability, they are having more and more tough time because their normal routine is absolutely gone asunder. The challenges of online learning coupled with the lack of creational activities is again causing a lot of frustration to both the parents as well as the children. And one of the hardest issues is when the child may be having ASD, autism spectrum disorder. So it is also very, very important to understand that children with ASD will become more anxious, more grumpy and unpleasant due to the current situation. And psychiatrists have also analyzed that the number of internet addiction, especially in this lockdown era, has increased, and that is creating vulnerability to depression, anxiety, and even substance abuse. So in managing children, particularly if they have slight or to a moderate or either higher extent ADHD, or if they have finicky habits of eating and slow learners, or if they are suffering autism, then if there is social media addiction, socialization challenges, all this is complicating due to the COVID-19 situation. Attention deficit hyperactivity disorder is a developmental disorder where the child is not showing enough attention span, lot of distraction, hyperactivity, and restlessness. So that in the condition of this lockdown, this inattention and hyperactivity becomes more of a problem. So it is very difficult, whether it is for a pediatrician or a pediatric dentist, to manage children who may be having some symptoms of ADHD. And that's where people like Dr. Ghousia madam have dedicated themselves to work out certain strategies for better management of such cases. Autism is another challenge, which is again coming over to various pediatric cases as well as in the general family practice and dental practice also. In ASD, we see not only the various types of expressive and receptive disorders, but there is a delay in the social interaction. They are a little bit, highly introverted type of behavior, and they like to be repetitive in their behavior. In fact, it is suspected the very famous Einstein, who gave us the formula E is equal to mc squared and was known to have an intelligence much, much above the average. He did not speak until he was 3, and his speech development was much slower and he was also not so very interactive. He was a highly introverted personality. But like any autism child, he had a talent for understanding very complex systems. So this is one interesting feature about autism. So autism's early signs include that they don't like to mingle much with other children, the social communication is poor, and they also have got interesting signs and symptoms such as being preference to being alone. So these are some of the important aspects related to ASD. And children require effective parenting, whether there is a lockdown or not. Healthy food, healthy life, education, lovely career. That's what all of us are trying to give, isn't it? Well, that is where, even the dental care is becoming a challenge for meeting the healthcare need of children with special needs. And Dr. Ghousia Begum Madam has got a passion for providing oral care dental practice in challenging situations, especially in the case of the special children. So dental healthcare and research unit at Gharonda is where she has established her practice. She is very popular as a pediatric dentist for such cases, and also she gives a lot of counseling and speaking webinars, etc. She is a most sought after speaker on such aspects. So she is specialized in pediatric and preventive dentistry. She also knows in depth the child psychology and child behavior needs, especially the children with specialist needs. And the sensory informed pediatric dentist also in her makes her have a very inclusive practice, including for the palliative oral care of the special healthcare needs. She is at Dental Healthcare Research Unit at Gharonda at Hennur, Bangalore. In fact, she reminds me of Palak Muchal. Now, she is a very popular singer. She also has got a passion for kids, and she has created a Guinness Book World Record by contributing to the heart surgeries of 2,200 children. So such passionate individuals are a blessing to our society, like Dr. Ghousia Begum Madam. She is an ex-associate professor certified in conscious sedation from Vikarabad, external pediatric psychology at Nimans. She is certified in sign language so that her communication with special children is far better. And she has also certified in early intervention program for children in autism, and she has an online interactive course treating patients with autism in a dental setting. She has done that course, and she is having a fellowship in palliative care from Kidwai. She is a senior consultant fellow at Apollo White, and she has studied at M.R. Ambedkar College, B.R. Ambedkar College, Dental College, which is one of the renowned colleges where she did her BDS, but she is very happy and has warm memories of her active learning at the College of Dental Sciences belonging to the Bapuji Educational Society, Davangere, where she did her MDS. She is the editorial board member in very renowned journals, including American Journal of Medical and Dental Sciences. She is a reviewer for a dozen journals. It includes Microscopy Research and Technique, Journal of International Society of Pedodontics and Preventive Dentistry, Journal of Dentistry and Oral Hygiene, and so on. You can see the names for yourself. It can be a mouthful to read all of them. And she has several publications in national and international journals to her credit. These are her action photographs where she is treating all the children with special needs, and she has her own techniques, and she is a practiced hand at doing it. She is known to give very evocative and absorbing talks on how to take care of such children and make their life better. She is a blessing to the parents of such children also, because she is giving them good guidance, inspiration, and support. As you can see, her dedication is awesome, and you can see her at various places where she is representing her own expertise. Her professional goal is to treat special or differently abled pediatric patients for improved oral health, management of cleft patients, and speech defect children. And this is a super specialty in special care pediatric dentistry. Awesome, isn't it? She has also written a book, which you can see here. And Group Pharmaceuticals is very happy to support such dentists who are creating a world full of healthy smiles and laughter. We offer excellent products such as Shy XT, we offer Shy NM, and we offer the fluoridated bioactive glass L-Sense. But Omnident is doing very well thanks to its comprehensive action. Fresh Chlor is reducing the viral load, including in the chairside procedures. And for a wide spectrum of patients, we have uh, pastes like Inafix, which is non-fluoridated and is vouched for by many pediatric dentists also, and Pediflor, which is doing extremely well for the pediatric practice. So avoid the contact greetings, and the take-home message is the dentist does not just take away your dental pain, but he or she makes a life-changing contribution. So always consult your dentist. He will change your destiny and boost your smile value. So the professional goal being taking care of the specially and different abled pediatric patients for oral health. Really great, madam. We salute your dedication, and I hand over the entire audience to you. Thank you very much. Over to Dr. Ghousia, madam.
Yes. So I'll switch off my video so that the presentation is focused, sir.
As you wish, ma'am.
Yes. Yeah. Hello, everybody who is present today for this topic, which is little out of the context of regular pediatric dentistry. So, as pediatric dentists, we always focus on the oral health, or it is more anatomically focused branch. Any dentistry or the whole of dental branch is basically anatomically focused. So we tend to think only of the oral cavity, the teeth, the tongue, the cheek, mucosa at the maximum, the soft tissues. But then off late, we have started thinking about the general manifestations and the systemic diseases which may afflict and show up into the oral cavity. So somewhere the awareness on the systemic conditions like diabetes, so many other systemic conditions have been outgrown, and most of the dentists have been aware of it. The whole idea of presenting today is to join the dots and include the mental illness as well. So when we look at the missing link, the mental illnesses, which can also impact our oral health or the oral hygiene of a child. So most often than not, most of our dentists are overlooking this, and this is where I thought I would just have a short talk. This was in reflection or retrospection during the pandemics, wherein I thought I would just give an overview just of few pediatric mental disorders or the psychiatric conditions, which may not be very familiar with every dentist, but of course. After Sir spoke, I was very glad that Sir is aware of autism spectrum disorders and attention deficit hyperactivity disorders. But when I started my career, like around a decade back or something, so there was a lot of a lack of awareness, and this presentation mostly would be less of theory, and I think most of it would be reflection or my past experiences, wherein I would just tell how I went through and what were the strategies and how was the journey throughout to get into this specialty, basically that is more towards the special needs of pediatric dentistry. So I would just brief out a few conditions and not very detailed behavior management, because that would take another seminar on whole. But yes, of course, I would give few of the techniques which I would be, mentioning here and there during the case presentations. Verbally, I would be telling my experiences during those, learning procedures, or when I encountered a few cases in Enhance when I had my externship going on into the pediatric department number 14. I can never forget that. So I would tell you how how was the journey, because last presentation did provoke a lot of people to ask how was this all. So I would just give, and it would be focused more towards the pediatric dentists and the dentists who are looking forward to take initial steps and follow something like this. So this is just a very brief overview with a few of the reflective experiences. As I told you, why what initiated the child mental health disorders to learn for me. So there was this child around, like the eastern part of the city where I was practicing or consulting, something like in pie layout, wherein you have a 2-year-old child who was very withdrawn and not at all responsive or reactive. So very untypical of a child. 2-year-old child would have apprehensions, fear. That is how you see children. And then when you have the experience of seeing at least around 10 to 15 cases per day in, courts down Gire, so many children you're exposed to, and plus so many consultations, then you see these typical children who are not so very easy to handle, and then you're called for these children so that you can complete some invasive procedures like pulpectomies, or the swelling emergency treatments. So this was something very curious and intriguing for me, why this child was very not responsive to the when I injected local anesthesia. And when I started drilling, he was very passive. He didn't even want his parent around. I mean, too unlike for his for the child of his age. So that's something intrigued me, and I just put, after building a sufficient rapport or a reasonable rapport with the father, and the child, surprising, was always, accompanied by the father rather than the mother, which is again very unlike of that age. But again, mother was preoccupied with the professional commitments. And then the father realized that I was trying to hint, and I was just telling, if you could take a opinion from a pediatrician or developmental psychologist, because I just see there's something missing in this. The child is not seeming to be very responsive, like the age appropriate behavior. And somehow this didn't go well with the mother. And the mother came in and started reacting in denial, anger, frustration. And she did have a word with the pediatrician attending the child. So the pediatrician denied any of the milestones being missed. There was absolute eye contact. There was no eye contact at all with the child. There was no pointing, there was no cueing at all. And then the respective pediatrician didn't find anything fishy with the child. And this mother happened to question me, after all, you're a dentist, and when pediatrician is negating your commands, then you are nobody to tell. And somehow then, life moves on, and we moved on with different cases and different case consultations. And I was forgotten. The case was forgotten because the treatment was accomplished. 2 pulpectomies, I think, were done in the child, and few fillings which were, culminated and forgotten. Then later, 6-7 months back, the same mother seeks an appointment and checks my availability in the same particular clinic, and wanted to have a word with me, not for treatment but just personal talk. And that is when she told me, I lost 6 to 7 months of my child just by not listening to you. And that was something which was an eye-opening event for me in my life. And she told me, just being an advocate for special needs, or being an advocate for mental health care for the children, why don't you turn your advocacy into an activism, and you go and seek some more knowledge, hone your skills, and certify yourself. Because the whole idea I rejected. She confessed her, she confessed why she did reject me or deny my thing was because I wasn't certified, or I wasn't, trained. Of course, she was very right, and but then she did guide me, and she did tell me, why don't you just go and do something for the field? Because this realized, and the mother by then had left her full-time job and became a shadow teacher of the same child in the school of special needs. And then today the child is in the mainstream school. Initially, the child for first 5 years, because of early intervention, was a National Institute of Open Schooling. That is wherein you have the special needs kids being treated and taught, actually. And the mother was lucky enough for teaching the other kids, as well as shadow teaching her own son. And she found that very pleasurable activity, and then she found purpose for her life. And the child, of course, is because of the early intervention of that early age, the child entered the mainstream. Of course, the child is on spectrum, but with few symptoms. But of course, there is a lot of difference in the child. So that is when I moved on to hone my skills. And that lady, or the parent, is the one who guided me and told me to go. And I did experience a lot of learning in these prestigious institutions. I could have the opportunity of developing an access with these people. And of course, it wasn't easy to get into externship, because I was looked, oddly upon, because being a dentist, why is she coming into a psychiatric department? And probably she's just looking for some glamorizing, kind of role, or taking few selfies with these special kids. And those kind of things were looked upon. And then somehow I was made for 4 to 5 hours wait to just prove or assure them that I would be a serious. And then I was a faculty already back then when I entered the NIMHANS institution. So they were looking, if I would, as a faculty, be comfortable joining the postgraduate students of the psychiatry and learn with them through the session. But then learning is, never easy, and it has to come with a lot of sacrifices. So then I got the opportunity, and I am grateful to Mr. Shobha Srinath and Dr. Satish Girimaji for giving me the opportunity, allowing me into these departments of pediatric psychiatry in NIMHANS, allowing me to even witness the exercises, the diagnostic sessions. And trust me, those are very draining sessions. And when people think that psychology is an easy job and it's a very luxury lucrative job, it is the most draining brain draining job, and most of the people are still stigmatized and do not even consider the psychiatric illnesses, unfortunately, as real illnesses. And likewise, more unfortunately, they do not even consider the pediatric challenging behaviors or the pediatric psychiatric illnesses as the real illnesses. They always overlook, so they do not actually consider. Now, further moving on to actually implying this into our branch, that is our pediatric dentistry. Why are we speaking or thinking about pediatric psychiatry in our branch when we are being pediatric dentists? Now, we should not forget, as pediatric dentists, we are, we have the onus of handling a package, that is the child. It's not just the focus, not just the anatomically focused area of oral cavity. We're looking at the whole child, and then we are also looking at the combination. It's the parents child combination always. So you get a whole package. You're just not treating, you have to interact with the parents, interview the parents to understand the child. You understand the child, you interview, and then is when you realize these are the kind of behavior support theories or behavior guidance theory. I'm not using the word management, because we are not here to manage the behavior of a child. We are always either intervening the behavior if it is challenging children, or we are guiding their behavior, or we are supporting the behavior. So behaviorally managing the children is not something which we should be doing, and it is not the right part. None of the individuals should be managed. They either have to be guided, supported, or intervened as per the behavior of an individual, and more particularly if it is a child. So definitely, to understand the reasons behind such a particular behavior, we need to have some academic basis of the psychiatric illnesses, particularly in children. So that is when we have to come to this topic. And again, we are being, like I just told you, mentioned example in the introduction slide, we become the first contact child healthcare workers. Unfortunately, the child came to me when he was 2 years old, and somehow the other practitioners missed out the milestones, the delayed milestones, or the age appropriate behavior wasn't there with this child. So sometimes the pediatric dentist, because we have to look at the oral cavity since the 6 months of age, even during the gum pad staging, and even as per American Academy of Pediatric Dentists, we do have to see a child with the first eruption of the tooth, that's as early as 6 months of age. So it is our utmost responsibility to keep in mind what are the reflexes and what are the developmental milestones the child will particularly go through. If we miss this, we are not doing justice to a profession. We are just looking at the anatomical area, treating, but we're not treating, we are not being wholesome healthcare professionals. So it has to be very important that we have this basic skills. And I like to quote, the Buckminster Fuller's quote: when you want to change a system, or you want to fight against a system which is existing, you cannot actually do it, but you rather build a model wherein you try to make the existing model obsolete. So this is some attempt wherein I try to, as much as possible, create awareness, advocate the special needs, and also, more particular, the fresh pediatric dentists who are into the branch to take an extra effort of getting into the pediatric psychiatry, because developmental psychology is at most important for our branch. Now, coming to behavior. So we are narrowing down to our topic as we move through the slides. So why do we need to understand the behavior? Why do a person need behavior? So behavior is basically, the functions of behavior basically are, from the child's point of view, is to gain attention from the carer. So the child is seeking attention from the carer, and that is when he's behaving in certain way. The other reason the child is behaving is the escapism. So you put a child on a chair, dental chair, you see the stomach upset, the child wants to go to bathroom, washroom, and then wants to drink water. Suddenly the child is thirsty or hungry. So those are escapism kind of behavior. So this child is jittery and trying to search ways. So that is because it wants to escape an unpleasant situation or avoid an aversive situation. It could be our dental clinic. So you should know, as a dental practitioner, that the child is genuinely being hungry or trying to escape. Then there are some tangible experience. So of course, if the child is pampered well at home, and he thinks this behavior would help his parents to bribe him into Barbie dolls for the girls, or Hot Wheel cars for the boys, then definitely the child would say, acha, you will give me this, then I'll try to sit and I'll try to open my mouth. So those are the kind of things the child seeks behavior for. And then of course the sensory. So sensory is already spoken in the previous presentation, I think. So sensory is based, and the child is overreactive to the light, the sound of the suction, the air odor, and of course, when we're preparing cavity, the drilling, so the smell. So some children try to kind of find an excuse, the cavitation preparation or smell is quite nauseating, so they don't like it, so they do not want to continue the drilling process or the dental treatment in concern. So these are few of the circumstances where the child, utilizes behavior for functioning. So coming on to the behavior. So behavior is something which actually stems from the need. So it is regular. So the child, we did see in the previous slide, the child is trying to seek, the functions like attention, escapism. So those are regular behavior. Now what becomes a challenging behavior? So challenging behavior is something which does not stem from a need. It stems from an emotional disturbance, an underlying psychological trait. So this is different from a regular behavior, which is age appropriate. Now whenever we're talking about challenging behavior, now challenging behavior seen in a 2-year-old child or a child who is, still developing at around 5th year of age, those are not challenging behavior. So we need to have that sense of ability to understand which is age appropriate and which is challenging behavior. Now challenging behavior is otherwise called as problem behavior, difficult behavior, socially unacceptable behavior. So these are different terms, otherwise it's called. And challenging behavior, the criteria is it is self-injurious. It is injurious to the child as well as the surrounding people as well. And another criteria is that it lasts for 1 hour, and unless personnel comes and intervenes to prevent the disruption or the damage which is occurring. So it can sometimes last a few days in a week or few minutes in a week, but then it is so aggressive that you still need an intervention from a external person to stop the behavior to prevent the further damage. So that is when you categorize that it is a challenging behavior. So challenging behavior can be self-injurious, like head banging, scratching, pulling, then aggressive behaviors like biting, scratching, stereotyped repetitive movements, which is seen in most of the neurodevelopmental disorders also. So these you have to keep in mind. So you, again, as we proceed on with the slides, we would understand how to understand that it is neurodevelopmental disorder or it is just purely behavioral. So then we come to the non-person directed. Now here I would get you all to notice that there's a condition which is known as kleptomania, wherein the child has this urge to steal, though it is something of not help or it is of not of economic gain, but then it has an urge. So this comes under an obsessive compulsive disorder or impulsive activities. So non-person directed kleptomania is one of the outstanding, or which I would want you all to notice. So this is quite often seen in children, apart from damaging the property, hyperactivity, yeah, of course, stealing, I did mention. So moving on here. So are we really, is it really important to address this kind of behavior, challenging behavior? Now, this is very important because one thing is for the welfare of the whole welfare of the child, and also as a healthcare professional, especially the first contact healthcare provider is pediatric dentist, it becomes an onus on yourself that you need to look at it and because childhood is very, very important in one's individual. So anything which is implemented in children, that is the habits, the good or the bad habits, or any environment, so these go a long way in creating the future citizens of the nation or society. So the people who are involved with children, basically the teachers, the parents, or any healthcare professionals like pediatricians, so all of us have inevitable responsibility on ourselves to understand why a child is behaving in certain way. So it becomes a very big responsibility for us to, for the welfare of the child and eventually for the welfare of the society in future. So paying attention to the child and not just the behavior. So the child in particular has to be seen, and behavior can be overlooked, but the child behind the behavior has to never be overlooked. So you need to reason out, you need to figure out, of course, it's not in our domain as pediatric dentists, but at least keeping a brief idea about this and, taking the parents into confidence and referring these kids to this particular specialists who can help and guide the children. Early intervention is magical. So as early as before fifth year, the children can turn to be neurotypical kids, and the behavior can be tamed, cajoled. So it's very important to catch children at this age if there is something which is not appropriate for that age. And it is just not that child is giving us a hard time in clinic or at home, but child itself is having a hard time. So you need to give that empathy with the child. And if you really feel that the child has to be given attention, this is the extra effort from the pediatric dentist I request to be taken for. Now, the importance of behavior, of course, for us in dentistry is very important, because our treatment is completely topsy turvy if the child is not behaving well or running out of the chair, and also the child is trying to communicate with this sort of behavior towards us. Sometimes the child is non-verbal, the child is still not developed the language, like Dr. Sunil had already mentioned in the previous slides. So the child is trying to be using the gestures, or sometimes using the hands or behavioral actions to communicate to us, to convey some messages to us. So we need to understand this is a means of communication. The social life is affected, the child parent relationship and the child parent relationship with the others surrounding family members or the peers in the school, the teachers, it's all affected. Likewise, it's also affected with the healthcare professionals, because we are always packed with 10 to 15 cases per day, and we hardly have time, and we just want to finish. And if we cannot have the patience to see this particular child, we just push the child to another door. So this is actually exhausting for any parent, because you're constantly being pushed from door to door and nobody is actually looking at the child. So that becomes the social life is affected of this child. And if we want to address the behavior now, like I said, because it's a very important stage of human life, the childhood, then in future there will be a problem, and we might land up with societies with increased criminals, rape activists, and so on. Behavior takes away all the treatment time, of course, at the dental operatory. Then coming on to the pathological, psychopathological differences between the behaviors we have in the childhood, especially, which is seen most often from 4th, 12 years of age. We can categorize them in internalizing behavior as well as externalizing behavior. Internalizing behavior is completely dependent on the parents or the parenting styles or parental traits. The child being brought up in a particular manner affects the child's traits as well. So internalizing behavior are inherent and which are passed from intergeneration from the parents themselves, and they can basically be sulking, anxiety, fear, very self-oriented, directed inwards. Basically, the external behavior is something which is visible and which can cause a lot of trouble to the people around us, and this is developed from the surrounding ecological environment or from media exposure. So this is basically hyperactivity. You have conditions like which we would be again moving on the slides and understanding. So basically we understand that internalizing behavior is something which is grasped from the parents, genetics, and the internal traits of the child itself. Externalizing behavior are seen visibly, and they are damaging quite extensively, and it could be harmful for the people around. So developmental transaction of child's behavior, it comprises of caregiving environment, that is your parents, basically the parents or the grandparents or the siblings. So the environment of the caregivers and the child's own characteristics or the temperaments, the traits with which the child is born with, and ecological context, that is the surrounding atmosphere, the peers, the school atmosphere, and of course the media, not forgetting the media at all this time. So we are coming down to concerns, since we need to treat the child in the dental operatory. So we are treating a combo package, right? So our concerns basically would be to understand the parenting style. And if we are treating special needs parents, so we need to even understand their parenting styles as well, and their stigmas, the associated, the grievances. Sometimes there's a conflict between the spouses, there's a blame game, because when you have a special needs child, life is not the same or easy. It is not as it is. The parenting doesn't come with a manual or instructions. The parents are juggling with trial and error procedure, and if it's a first child, even more difficult. So they're seeking advices, they're learning from Google, and they're looking at their parents themselves, and most important manual for them in front of their eyes is their own parents, each other's parents. So parenting style again can differ between father and mother, and likewise the parenting style also differs from where the father and mother had learned or seen the live manual in front of their eyes, that is their own parents parenting style. So that influences the child, of course. And the other thing is the Pedia-Psychiatry, that is the inherent quality of the child itself, the genetic traits or the temperamental traits. So these are the two important factors for us pediatric dentists to take in mind to actually support the child's behavior on the dental chair. Only then can we do our effective pulpectomy, place our stainless steel crowns, provide a preventive regimen, diet counseling, and so many other things. If diet counseling you have to do, or preventive measures you have to do, you have to convey a proper message to the parents. So for that, you need to go into the depth, understand the family dynamics. The family dynamics includes the parental relationship with the child as well as between themselves, and also their perception towards the oral health. And only then, if you're our branch basically is pediatric and preventive dentistry. So of course, I'm sure most of us are also parallelly practicing the same. So both of these co-packages become very important, and understanding of there is as more important. So coming to the parenting styles first. So, quoting Cox, a child can never be better than what his parents think of. So, as per Diana Borman, that is the most famous categories of parenting styles, which we keep repeating and learning from undergraduate days. That is your authoritarian type, authoritative type, permissive, negligent type. So, authoritarian type is something very strict. The child is not allowed for open communication. The parent is the boss here, and it's like a dictatorship, because parents do not give any scope for the child to speak. There's no way open communication. Now, authoritative is something which all of us look for, and we would prefer in our dental operatory. It's more democratic. It does show authority, but also allows the child's say. So here the child has a say with the parent, and there's an open communication scope, and child develops a psychological autonomy. So it has its individual characteristics. Whereas authoritarian child, the child brought into the authoritarian type is lacking self-esteem, as well as the child is shy, less and confident, though obedient and very mannered, but then internally the child is underconfident and with low self-esteem despite being highly proficient. Whereas authoritative, even if the child is moderately proficient, since the parents are encourageable and democratic, the child grows out of its of its domain and flies high. Then coming on to the permissive parenting style, here the parents are permitting everything. Here the child is the boss. So anything and everything is agreed upon when the child says, without being assertive. And moving on to the negligent type, where the parents are emotionally distant. Either they're busy with prior professional commitments, or they were really not prepared for parenting of accidental parenting. So these kind of parents definitely have a parenting style of negligence, wherein the child eventually becomes subjective to child abuse or behavioral disorders. So this kind of parenting is our focus, mostly leading to behavioral disorders or the psychiatric illnesses, as the behavioral disorders, most importantly being oppositional defiant disorder, conduct disorder, and few conditions like child abuse and neglect. So these conditions are seen in negligent parents who are emotionally distant. Now, another category of categorization of parenting styles is the drill sergeants, wherein the parent is basically commanding and instructing constantly behind the child. And also there is another type of parenting which is not mentioned here, that's the martyr parenting, when the parent is ready to do anything and everything for the child. So they overdo, they kind of sacrifice everything, all their luxuries, just so the child is happy and gets everything the child is demanding or seeking help for. So that's martyr parenting. And here we are also having helicoptering parenting. So this was made popular by Kajol. That is, I think, Helicopter Ela movie was released, I think, 2 years back roughly. That actually shows the over-parenting style, wherein the child is being constantly hovered around by the parents, everything, every academic decision, and the child loses the, it's kind. Some people do debate that it's also a kind of child abuse, but then the debate continues. So we don't know this is just a parenting style, or also it can be characterized under the abusive style of parenting, because the child does not have any kind of, there's constant moral policing, there's no independency, and there's no way the child can escape. So if you psychologists do consider this as an abusive kind of parenting. And then we move on to the consultant parenting, wherein the child is spoken by, and very dignifyingly the parents do guide and provide a way for the child, so that there is a two-way talk between the parenting, which is again appreciable, and we do recommend this kind of parenting as well. But of course, most of the parenting styles become a combination of a lot of many things. The parents struggle to kind of change the behavior and parenting style for one child, and then for they adapt another parenting style for another child, so that leads to conflicts between the siblings as well. And also, they do not want to kind of repeat the parenting style which they encountered during their childhood. So I did have this kind of patient wherein complete early childhood caries, uh, rampant caries basically. So there was no scope of kind of, and this child again was around something not less than 3.2 or 3.3 years. And the reason very evidently was because the parents have over pampered, and the whole of the refrigerator, I believe, was filled with Cadbury's chocolates in particular. I did ask them, why was this? Because the child is every day developing swelling on one particular teeth or the other, and then there is no scope for extraction at that particular age, because you need to save the tooth and then handle the child. Likewise, the child has to go through the trauma, the parents as well going through the trauma, we are doing the hard work to give the justice to the child. The only comment the father gave me was, because madam, I can afford. There was a time when eating one Cadbury's chocolate in my life was a luxury, so my parents would give it only on my birthday. So I didn't want that kind of upbringing for my kids, so I filled the whole fridge with Cadbury's chocolate. So of course, those kind of things do happen, and that is where we as pediatric dentists need to intervene and speak to the parents and make them understand that there's always there is no extremes of pendulum. You need to have an balance of state, an assertive state while disciplining the parents. You cannot have a drill sergeant. Of course, the historic parenting was completely parent oriented. There was no consideration for the children, we do understand. But today's parenting should not be over leniency, but there should be some assertiveness, authoritativeness, because age appropriate. The child does not know few things being right or wrong at that particular age. So that balance has to be maintained, and it has to be conveyed in a very gentle and positive manner to the parents while we are counseling the parents. And then it's very important to give ears to the parents, basically understand why they're behaving in such a manner. We do focus so much on the child, but do we forget that the eating style, the dietary concepts, everything is inculcated from the parents, the homely atmosphere, the family dynamics. So we need to give that extra time and understand the parents' grievances, find out why the parent is behaving in such a way. So then I had to speak to this particular father and understand, see the whole idea of the child being suffering because of the constant eating of chocolates is, then the child loses nutrition because the teeth are in a bad shape. Some are savable, some are not savable. So the whole growth of the child as early as 3 years was questionable. So that is when he understood, his mistake. Of course, moving on to the slide here, proxy parenting. Proxy parenting is basically when the biological parents are overtly busy with the professional commitments. Then you have grandparents doing the proxy parenting, or the nannies or the caretakers doing the proxy parenting. So also, this is when the parents are present and they're busy with the professional commitments or other commitments. The proxy parenting, coming to the special needs parenting, when the special needs child loses their parents, so who is looking after them? So these are very lingering questions and very bothersome questions to the parents of the special needs children, because they would do anything for their child, irrespective of the what the child what they were blessed with. So what after them is the most important concern and most worrisome concern. So that we'll have to look into some of the national agencies register. It's very important to get enrolled for the child, always safety. And I think most of the parents were concerned about this, and how do we go about most of the especially neurodevelopmental disorder kids, because we could only gain few micro gains in these children, not much of the development would be seen intellectually. So what after them? So that is the trusts which we'll have to look, and I think MHANS is the best place to be guided there, wherein they do enroll these kind of kids and the parents are guided. Now coming to the special needs parenting in particular, so of course, to understand this concept, there's a beautiful book which can expand our humanity actually. So this is from Andrew Solomon, and this gentleman has so many YouTube, he's a very good orator, and his YouTube talks are quite inspiring to listen to. And this particular book was out by 2012, exactly at the time when I was kind of going through all this courses. So it actually works, this is a 10-year-old, this is a work of 10-year research wherein he interacted or interviewed 300 families of different diverse conditions, not just neurodevelopmental disorders like autism or ADHD, cerebral palsy, Down syndrome, but also with transgenders and also rape survivor kids and so many other conditions, also physically handicapped, so various other kids. And then the family dynamics were discussed, wherein the family is struggling between the acceptance and the treatment. They're struggling for fixing the child, or also accepting the child and moving on, or cherishing. So that's a very beautiful book. If we could grab and understand, then we would understand the parental psychology of special needs as well. So here, coming into the three categories: compensatory parenting. So these parents are basically, the moment the child is diagnosed with a particular condition, clinical condition, they kind of overdo parenting, and they try to compensate, and they fulfill every needs which a neurotypical child would want in their life. So they constantly are working for the child. There is no they do not expect another child, they do not want another issue after this child, because they want to focus all around this child. So that's a compensatory parenting. And then we come on to the parental straddling. So parental straddling is basically the parent is fluctuating from different thinking zones. So first thing is, the parent is still in the past, wherein the child was born, and pre-birth, prenatal status, wherein the child, where the parents were having few intentions or few expectations, and then right after birth, and then so on, few circumstances wherein the diagnosis happens. So they move on to that mode, and they go into sulking mode, and then they come to the present situation wherein they see the child struggling, and they want to fix the child, and also they think about their own feelings. And so this is a parental straddling situation, wherein they're juggling with their own thoughts constantly. Again, expanded parenting, so they expand the practices, accommodate the needs of the children. So this is again a preferable method of parenting for special needs. Other parenting styles for us to know, of course, is the foster parenting or the single parenting, wherein the families are divorced. That also is very important, because it does have its share of psychological impacts on the children we see. So we do need to have a proper interviewing with the parents to understand which style of parenting we're seeing. If it's a foster parenting, which is not mentioned here, and the single parenting post divorce, and the other things which we are mentioning here is the altered parenting. So altered parenting is something where the parenting is, regular parenting is going on, and suddenly midway, like fifth year or sixth year of the child's life, or eighth year of the child's life, the parents realize and get into the diagnosis that the child is suffering from this invisible or psychiatric illnesses, and then suddenly their parenting style changes. So here the child is the same. I mean, the child was behaving the same way. It was all the same, but the parenting style completely changes, and they start feeling the guilt of being incompetent for themselves, and they start looking for expert comments, be it from pediatrician, from therapists, from psychiatrists, and from dentists. So they somehow feel they have been incompetent, or guilt that they didn't realize the kind of parenting they should do. Now, the impaired parenting, of course, is there's some compromises wherein the social environment of the child's upbringing is compromised because of the impairment of the parents. And another thing which is a controversial parenting style, just for mentioning, because it is not completely discarded. The most of it is only discarded in the perspective that this cannot lead to autism spectrum disorder, of course, because there was a blame way back early in like 1930s or something, wherein the cold mother syndrome, or the refrigerator mother theory, was where the mother lacked warmth, and that was to be blamed, because it's a common notion to blame the mother immediately as soon as you see a defect with the child. So unfortunately that was done back then, but then later it was discarded, because autism proved to be a genetic disability, a neurodevelopmental disorder, of course. But then this kind of syndrome does exist, this kind of parenting does exist, wherein the child, the mother or the parent is emotionally distant, or cold. So whatever reasons, but this kind of parenting is still existence, which leads to your Munchausen syndrome in proxy, and otherwise the abuse or neglect in children. Yeah, so we're moving on to the child abuse and neglect. So where child abuse and neglect is in negligent parents, like I mentioned, or the cold syndrome parents, where the parents are not completely focusing on the children, either because of their own psychological traits or because of their professional commitments. So the child is at the stake of exposure to sexual abuse from the family, sometimes, which is incest. Then also intentional drugging or poisoning from the caretakers or from the parents themselves. Munchausen syndrome by proxy, I was mentioning, and dental neglects, wherein the child suffers with early childhood caries, rampant caries, and the child is not brought in on particular time to attend. When they become root stumps, the child comes. So that is a huge, that's considered as an abuse parenting style. So safety neglect, the child constantly is falling, trauma is happening, burning, poisoning from the medicines at home, which should not be kept at the reach of the children but are kept. So emotional abused child, and physically neglected child. Physically neglected, wherein there is no hugging, patting, appreciation. So physically the child is very withdrawn. So what do we do as clinicians or practitioners here is like psychological debriefing, or it is called as a psychological first aid approach, wherein you follow three principles, that is look, listen, link. So that is very important in this kind of condition to for pediatric dentists especially, or any child healthcare provider, that you have to first look. The condition is intentional, or it is provoked by some incident at the family. So look, listen to the parents, of course, or the child, and link the matter. So you should have multiple informants here. So just taking a history from one parent, single parent, you'll have to take individual, especially in kind of suspicion, when you want to confirm few things of abuse. It's very important to have multiple informants from the family members, from the teachers of the child, or separate parents make to be seated, and of course the child individually separately to be taken. Now, these manifestations are shown in the child's oral cavity as well, wherein the child's teeth are being pulled, the hair is being pulled, and this also the genital mutilation. There was a case, I forgot to mention here, but there's a case of child abuse in dental literature, maxillofacial glossy fibroma, wherein the parent intentionally, of course, stuffed cotton inside the oral cavity, and that led to a kind of cottonoid mass reaction. And the clinician had to work it out around and then realize it was a child abuse case. So these cases have to be reported to the national agencies or the concerned authorities. Now, moving on to the Munchausen syndrome, it is most recently being termed as factitious disorder imposed on another, or fabricated or induced illnesses by carers. Now, the Munchausen syndrome was the term given by Meadows, of course, the Roy Meadows. So otherwise, it's known as Meadows syndrome. But before this, in 1951, Mr. Ascher was the one who had written trilogy of cases in Lancet, titled as Talking Sense. But then after that, it was not much paid heed. And then PC Meadow, Roy Meadow comes in picture, but then he was subjected to a lot of professional misconduct cases, and a lot of terminations happened. But in 1998, for his good fortune, he was awarded knighthood for the same diagnosis which he intervened. So basically, the term Munchausen syndrome has come from a person who back then, a Russian baron, that is an army personnel, after the war comes and gives outlandish stories, or some fantasy land stories, something like riding on the cannonballs or traveling to moon, and etc. So people were fascinated with his stories. So this kind of illness, which is very hard to diagnose, and it is termed as the hinterland of child abuse, which is not very easy. So this mostly is seen, the incest is of course the mother, and the mother should have the knowledge of the healthcare providers, as also the knowledge on the the body functions or the body terminologies or the healthcare provider. The mother is constantly manipulating the brain of the doctor. So there is intentional hurt for the child, so that the child's parent or the mother gains sympathy. and knowledge. So this should be differentiated from man lingering, because man lingering is something associated with economical gains or LIC or insurance. Here you do not have economical gains, but the satiation of attention to the parent from the clinicians. So there were cases wherein hematosis or hematuria in the diapers of the children were done from the mother's blood, and the diaper was given for diagnosis, lab investigation, so much so that the child even had to undergo for surgical intervention. So those kind of things. And of course, dental origin, it is very important, because some of the child abuse is most often seen, and mouth being one of the weapons with the teeth or the hands. So the hands and teeth can become the weapons which can hurt, and so the dentist has to be vigilant in these kind of conditions. Now, coming on to summarizing the parenting style. So, of course, we do know that authoritarian style is what we prefer, as mentioned earlier. So, now coming on to the next aspect, which is the uniqueness of pediatric psychology. So, psychology basically is the father of psychology is Logan Wright. But before this, Mr. Kagan had initiated developmental psychology. Again, over a period of time, nobody paid heed, and then Logan Wright comes into picture, and he coined this term, which primarily deals with children in medical setting, which is non-psychiatric in nature. But way back, much before this, during the Einstein's time, when Jean Piaget, being a genetics expert himself, but did mention about this theory, Jane Piaget's theory, of course, we did mention on the sensory motor, the theory which I spoke in the last seminar on the sensory seminar, which is the sensory motor, then pre-occupational, operational, formal operational, and so on. So this person had also mentioned that the child's brain has inbuilt psychiatric structure, wherein the child assimilates, accommodates, and equilibrates any environment around it. So examples being, two brothers, as mentioned by Paget, looking down from the bridge when they see people around. So the younger one is speaking to the elder one, telling I think roughly around 3-year-old child speaking to an 8-year-old brother that, there are so many ants moving below this bridge. And the elder brother corrects the younger brother, telling, yes, the people are looking like ants which are moving. So basically, the child is assimilating. So any moving objects it sees as ants on the floor. Likewise, any moving object is a bird for the child of that particular age, be it aeroplane or bird. So it takes time as you grow. So there is a mental structure for these children who are growing. So that was mentioned by Paget, and a beautiful line by Einstein was mentioned on his discovery, that this discovery is so simple that only a genius could have thought of it, and rightfully so. So we need to understand child psychiatry is a very intense field. So this actually revolves around the innocence of the child, the unconditional love, the forgiving nature, and the forgetting nature of the child. So it becomes a very unique branch in itself. And way back, all thanks to Logan Wright, wherein the marriage of psychiatry and pediatrician happens, and he was one of the pioneers to develop a developmental psychiatry or the developmental pediatrics, which is now known as developmental and behavioral pediatrics. Most recently. So the issues which we require in pediatric dentistry, concerned with the psychiatry is, of course, the parenting styles. And we do need to have that skills or the alertness to assess the developmental delays, the cognitive and motor impairment of the child. So reasoning of the explosive behavior or the inappropriate behavior in a child, and of course the deleterious oral habits or self-hurting habits, the reason, the management. So if we know the reason, and it's easier to manage, or it is easier to correct the habit basically. Then behavioral management of neurodevelopmental disorder children, and mystery behind selective or elective mutism, child abuse and neglect, parental counseling, adolescent substitute. So as we treat the adolescents, we should know about the substance abuse as well. So coming to the child psychiatry, so child is born with 9 congenital temperaments, activity, wherein the child is active. Now these temperaments, there is no right or wrong in the temperaments. So the temperaments is what makes the child unique, or eventually the individual unique. So these are unique to every person. So there cannot be anything right or wrong. Of course, anything exaggerated or anything which is disruptive in developmental process or behavioral process as per the social life or the developmental life is when it becomes a disorder. So these temperaments have to be credited and honored as individualistic criteria or the individualistic characteristics of the particular person or a child. So activity, the child is either overactive and very interested to explore things. Sensitive, of course, whether the child likes the sounds, what kind of temperament of the sounds or the lights or tastes. Like regularity, if the child is regularly going to the toilets, eating and sleeping habits are regular or they're random. Then approach and withdrawal, so whether the child is encourative, excited to explore the new environments, new places, or new travels, or the child is withdrawn and takes a warm up time. Adaptability, how well the child adapts to the new environment. And when I'm talking about new environment, we are focusing more on the dental environment basically. So negatives and positives, this is basically the mood of the child, how the child is more inclined towards the moods, like whether it is more positive, negative. Distractibility, whether the child is easy to get distracted from one. So distractibility helps us a lot when we are intervening the child invasively in the dental operatory. So we can immediately distract the child when we injecting the child or drilling the child, creating invasive procedures. Then persistence, how well the child continues in the particular habit. Intensity, high intensity and low intensity, then this child reacts highly, then it can be very exhausting for a parent or the clinician who's treating the child. The psychiatric issues coupled with behavioral disorders, few examples have been mentioned on the slides, which I think Dr. Sunil has already mentioned. We would be mentioning few particular conditions as we move on. So of course, we are moving on to the disorders of the pediatrics. So like Stars on the Earth, I dedicate the slide to Tare Zameen Par, which is actually a very well-made movie on the child psychiatry, apart from Children of Heaven or The Broken, and so many other movies for child psychiatry, which actually becomes a workshop for NIMHANS externship when we are going through the course. So there is only one way to see things until someone shows us how to look at them with different eyes. And so if we do not understand the different ways, we only see an uncooperative, definitely negative child. So unless we know the basis underneath, we do not see the underlying psychiatric or psychopathological or behavioral disorders of the child. So I would also like to mention Sarah Williams' quote here, wherein you're so fondly in love with these stars that, I'm not afraid of the night, which is associated or accompanied with these kind of children. So moving on to the conditions in individual, so oppositional defiant disorder. Now this is a very difficult disorder on the clinician when it is encountered in the dental operatory. Now this is an outcome of a negligent or emotionally distant mother. So we need to understand that, and they are easily cajoled, tameable children. It just needs patience, lots of love, and of course you should appreciate the child. Verbal appreciation, verbal reinforcement is very important, and they can be definitely negative, and they are basically harmful to the others around them than to themselves. So they can be very on the dental operatory chair, they can be kicking, biting, and really running out of the chair. So those kind of oppositional defiant disorder, and they both these conditions are almost sinking in together. They look very similar and they project very similar on the dental operatory. And also it should be understood that they're very hostile to your instructions. Any authoritative figure, especially the parents, the teachers, the clinicians, health authorities, and this can be very offending to few clinicians who do not understand the reason behind this. So this can put off, and the child is just sent back without the attention or the treatment, and that further aggravates the behavior of the child. It initiates, it becomes compilation, so reinforcement happens. So you need to negatively reinforce this habit. So negatively break this habit so that this habit is extinction. So we do know about the reinforcement. I'm sure the pediatric dentists listening to me know about the reinforcement, extension, differential reinforcement, wherein you're shifting the reinforcement to another practice. So you are not encouraging this behavior, but you're not even negating the behavior. So you are neither stigmatizing it nor romanticizing it. You're not even normalizing it, but you're dealing with it, guiding it, intervening the behavior. So those are the strategies which come when you are trained with cognitive behavioral therapy, that is the CBT. When you talk, the talking strategies, the family therapy, the peer therapy does consume time. It has to be up to the clinician whether it wants to, the child, the parent, the clinician wants to invest that kind of time with this particular family. but giving up on the child is not the advised way. At least the clinician concerned can refer this particular child to a concerned therapist, wherein the therapist could tame or cajole the child. Now, explosive child is, of course, the most difficult one. This is where I talk about the conduct disorder child. Now, this child could be very, very offending, because the child can spit on the dental operatory, on the clinician. They can actually spit on you. They can kick, they can bite so much that you bleed, your fingers bleed. So some physical restraint. If it's an emergency, attention needing treatment, wherein the child comes with an abscess, you do take a bite block, and you do aggressively, passive restraints, which are bite blocks or papu strips, can be used. Or I prefer personally the active restraints, the parents themselves, not even the paradental team from my staff, because I feel they do not do the right justice. So I take the parents help themselves, wherein they are actively restraining their own child by their hands and legs they're holding. And of course, the clinician or the pediatric dentist attending should be brave enough to put their hands into the mouth and start operating and relieving the child of the emergency abscess, or the infection which is there, and later work on the therapeutic aspect for the eventual kind of treatment planning. So this is something which I wanted to mention. So do not get offended by these kind of behaviors. There's a reason behind this. There's a negligent parenting, or there is an emotional detachment which has happened much early in age, or there is a post-traumatic disorder, stress disorder, which has happened. So when you talk to the child, come down to the child's level, confide into the child would definitely open up, and eventually they become good friends. So that patience is required from the clinicians who would want to attend to these children. Now, moving on to the ADHD, Mr. Sunil has already spoken extensively on the attention deficit hyperactivity disorder. I'll just speak about the dental aspects of it. So these children are so impatient littles. They're very good, but impatient ones. They are hardly listening to your instructions. So you need to be very brisk, fast. You do not. They bore very fast. So you cannot just give them stories or sit with your tell show, do technique, desensitization procedures, because they do not have the patience. So you need to pace up with their speed if you need to get them into confidence. And these children are more succumb to the orofacial injuries or trauma, because they're not sitting in one place. They're not sitting in one place because it's not because they do not want to sit in place. It's basically because inherently they cannot sit into one place. So they do need medicational help. Now, these medications which are given to these ADHD children particularly are cariogenic in nature. That's because the dry mouth xerostomia happens. So you need to have, there is a lot of medication which goes into for these children in the initial age. So it sets in as early as 4 to 7 years. 4 years actually, as early as 4 years, and it becomes a peak at around 7 to 10 years, and eventually over a period of time with a lot of cognitive therapies and medications, they actually taper down, but they can never outgrow this condition. This condition is here to stay with them, just like autism spectrum disorder. So you need to accept the person as is, but you need to modulate your approach towards this child. So make the crisp appointments, brisk appointments. Do not give stories, long stories. And of course, you need to verbally appreciate this child, because this child is constantly being scolded upon for being misbehaved, wrongly, of course, wrongly understood, and being constantly scolded upon for being misbehaved. So if your verbal appreciation and you're looking at the good and ignoring the bad behavior will definitely gain the attention of this child. And then another important thing is, as a clinician, you need to have that extra creative skills in catching their attention when you're drilling on your child or doing the procedure on your child. So you need to work on their brain much faster. So you need to give some creative kind of a story wherein the child, so for that you need to tap the interest of the child. Then you can revolve around the story, and you need to be really master in creating fantasy stories wherein the child is engrossed, distracted, and forgotten to get up and jump out of the chair. So the child sits for that little time till you can finish your procedure. So you need to be highly creative. I do remember one of the senior endodontist encountering this kind of situation wherein the child was being treated by me, had come to me and asked, if this was being actually taught in the curriculum of pediatric dentistry of, story building, being creative, and, then you cannot repeat the story again and again because the child gets bored. So you need to be very creative, and of course, if in the operator you have another child who is, waiting for it, or the ADHD child is the second child you're talking, and then you're treating with the same story, then of course you are going to be a failure as a clinician. So you need to be outsmart smarter enough, and then you can actually rule over the child and accomplish your successful, effective treatment planning pertaining to the dental origin. Of course, the symptoms which Mr. Sunil already spoke, that is the 6 particular symptoms from either of these categories, lasting for 6 months, would definitely give us a diagnosis of ADHD. So basically, this is comprising of inattention, hyperactivity, and impulsivity. So most of the talking is done by Mr. Sunil on this condition. So I would move on. And moving on to tic disorder. Tic disorder is most often than not associated or camouflaged or comorbid with these conditions of ADHD, autism spectrum disorder. So tic disorder is basically involuntary muscular movements or vocal tics. So that can be muscular or motor tics, or it could be vocal in nature, that is with the sounds. The child makes the sounds. So they can be little disturbing when you're operating on a child, but as long as it's okay and you're able to operate your work, you can ignore this kind of behavior. You can overlook and focus on, and accept the child as is. So this can camouflage, or this can be projected as a nervous behavior. And basically, there is an anxiety developed before this tics develop or initiate into a child. So the high intensity of anxiety. So this can be categorized into the category of obsessive compulsive disorder, or under anxiety disorders as well, as we move on to the slides. So here, as soon as the anxiety develops, the tics initiate, and then the child is relieved and gratified. So you need to allow that kind of gratification. If the meltdown or the me time is not given to this child, the child can potentially become highly uncooperative, and you might lose the appointment for the day. So you need to give that me time, or the contingent escape, which we read in our undergraduate curriculum. That the escape time or the me time, the contingent escape, which we the terminology used in our undergraduate textbooks. So another thing is, giving the splints to these children can actually give that sensory tricking, or the sensory satiation, wherein the moment the child bites on it, everything is focused or centralized, and the child calms down. Okay, and these tics are absent in the night, or especially when the child is asleep. So this is very important to note. These are very otherwise they are not neuromuscular in nature, so they are absent while they are asleep. So this again should last for more than 6 months, and then you categorize these children into tic disorders, suffering with tic disorders. Now coming on to autism spectrum disorder, these are little professors. Again, Mr. Sunil has spoken so extensively and very clearly on the spectrum. So we do know there is a three triad of impairments, wherein impairment in social interaction, impairments in communication, repetitive, restrictive, stereotype patterns of behavior happen. So I would focus, I was anticipating Mr. Sunil speaking on it, so I would focus on what is pertaining or helpful for us in pediatric dentistry, that is the social communication disorder associated with this condition. So here the child is most often non-verbal. So you need to go with the augmentative or alternative modes of communication with the pictures, symbols, the visual imageries before the child comes to the dental operatory. So you're giving them, a pre-visit picture. So the child is prepared for the steps, and child tends to get desensitized. Then of course we are doing a parallel talking. Parallel talking is something you're tuning in as a clinician. You tune into the child's body. That is, suppose I speak like the child on behalf of the child, just because the child is not able to communicate or verbally express it. So the expressive and the receptive language is completely hampered in these kind of children, unfortunately. So we take the initiatives of gestures like sign language. That is when the sign language comes into picture. So we're using gestures, pantomiming. Pantomiming is the skit. If you have a team, if you're going into a particular institution of special needs children, you do give a prior. Of course, the pandemic is stopped all the activities, but we do give a prior talk, or the prior enactment, or the skits for these children to understand. So that is pantomiming, wherein you have slapstick comedy. The children laugh, giggle. Of course, comedy and humor is universal language, so you do not need language for it. And language is something which is to be caught. It cannot be taught. This has to be kept in mind. So nobody can teach a child to talk. It has to be something caught or grasped. So this can be grasped for a non-verbal child in particular, so through actions, and your sign language comes into help. So parallel talking, I was talking about the parallel talking, wherein the clinician actually tunes into the body of the child and tries to talk like the child, expressing the child's feelings. So you're drilling the child and you're parallel talking to the child as if the child is expressing his feelings. Acha, so now the cavity is being prepared and the germs are moving out, and the suction tip or the vacuum cleaner is sucking. So I'm actually tuning in the child's language, and the self talk is something which I'm doing to you all right away. So self talk is wherein the clinician is constantly talking. Okay, you like this, do you want this? So I mean, self talk doesn't help much because the child cannot reciprocate at most often, and if you know that a child is a non-verbal child, avoiding self talk is advisable, and moving on to a parallel talk wherein you tune into the child's body and you express the child's behavior, and then the child corrects you if you're going wrong somewhere. No, so it is so nice. It's the drawing is happening so well into the cavitation tooth, and the child gestures you as a no symbol, and they say, oh, acha, it is hurting me little, doctor, can we go slow? So you're actually tuning into the child's body, and the child's confidence on you is extremely doubled up. So another condition which I would be talking on the autism spectrum disorder here, which is missed by Mr. Sunil, is regressive kind of autism. This is a regressive type, or you call it as a Heller syndrome, which is actually most often, or in my experience, I have seen most of the regressive autism. Unfortunately, though, as per worldwide statistics, it's only 40%. But then I unfortunately happen to see more of that kind of autism spectrum disorders, wherein there is a spontaneous regression of the social language, the skills developed by the child. So the child who was verbal, who was socially active, who was pointing out, who was maintaining eye contacts, is actually regressing, and he stops talking. So initially you get confused with the selective mutism, but then the child goes into the non-verbal. This can be very, very hurtful and very disturbing for a parent, because where the child was social, hugging, kissing, patting the regular child, and then its child's withdrawing itself, going into the sulking mode, being very introvert in behavior and male-like characteristics. So this the parents cannot easily take it very well. Over a period of time, they would wonder why the child is regressing. So that I just wanted to be mentioned. So this also has to be taken in consideration when you're taking case history. So you need to ask if the parents, if the child was once upon a time, the developmental milestones were crossed, and then suddenly it started regressing. So stereotypic movement is basically associated with autism more often, and non-self-injurious movements like body rocking. So we're concerned with the thumb sucking, lip biting, chewing habits. So our habit trainers come into action to prevent the children from injuring itself, and so we need to know if the child is just having the thumb sucking, because the parents do not or reveal the history. That most parents, if the mild spectrum child of autism, may not explain to you or may not even want you to know that the child is having autism. So then you are just focusing on your habit breaking appliance and correcting, and then you wonder, the parent comes back and accuses you, or corrects you, we have spent so much, and your 6 months therapy of thumb sucking, habit breaker appliance or whatever appliance, even your bruxism appliance, has not helped me out. So then you're wondering with the answers, you're trying to search, and then you do not know the underlying cause, that underlying sensory seeking habit which the autism child would definitely have. So the child needs a therapy. So those kind of things is where you have an upper hand. If you know the child psychiatry or the pediatric psychiatry, you can encounter the parents. So most often the parents would actually, you cannot blame the parents as well, because I did have an incident in St. John's Hospital when I was having a talk wherein this particular lady from Tamil Nadu was not had been to a dentist, and unfortunately the dentist who treated the child with autism did not know what is autism, and the child was injured miserably. There was bleeding, the cheek was cut, the tongue was cut, and she was very glad to see me there, and she was like, it's very good that we have taken an initiative to sensitize fellow colleagues on the condition, because unfortunately, most of our colleagues back then, at least about 10 years back, were not aware of what is clinical condition of autism, and if it could affect the children in particular, especially the child psychiatric condition. So likewise, she did also mention about, even the ENT specialists, the child first sees. So she was telling if these professionals, interprofessionals, could be sensitized. So it becomes our onus or responsibility, as much as we can interact with the interprofessional individuals. If you're working in a hospital setup, or if you're working in a team, then it's important to discuss with your co-colleagues and make them sensitized, make them inclined towards this subject if they're seeing the children at the early ages. So the mother was quite relieved when she got to know that at least one dentist has come, and her next approach was, please include ENTs and other healthcare professionals as well into this team. So the approach, of course, of treating these children for the habits, I'm coming down to thumb sucking again, not just the appliance. So you need to differential reinforce of other behaviors. Now, differential reinforces, you need to engage the child's hand in different activities. Like the thumb has to be kept busy in writing, or something like segregating of various dals of different sizes or colors, and then engage the child's habit, something interesting. You will have to be creative. Likewise, you will have to even implement the conditions in the attention deficit hyperactivity disorder. You have attention enhancement skills. The same skills can be used in your dental operatory if you want the child's attention to be grasped. So you do a treatment, you give a break, you could give a contingency escape break, then you give a child the playtime, and you're giving that attention enhancing skills as the playtime, so which you're eventually, or helping the child as well, and also helping your dental operatory treatment efficiency to go on well. Functional communication training, so these are alternative behaviors, so you can go on to the alternative behavior. Lip biting or chewing, you can give chewing gums. Lip biting, you can allow the child to talk, sing wherein your lips are utilized. So you need to cultivate few of the habits for the children. You need to work on that. So moving on to the next category, that is the anxiety disorders in children. So anxiety disorders, basically we would be talking very close disorders, which is specifically age appropriate. Separation anxiety disorder is very normal for a child from the age of 2 to 5 years. So the child is very comfortable, secure within the absence of, within the presence of family, parents, or the security of the home. So anything separation. So this is initially seen in the children, and it's very exclusive to the child. But then if it proceeds beyond the age of fifth year of life is when you start bothering about it, and that can actually lead to a concern, separation anxiety disorder. Now, developmental stage, if it is and then coming on to the social anxiety disorder. Social anxiety disorder is the social phobia, or the child not only being fearful to the outward community, but also is afraid of their own friends or the peers. So if they are constantly afraid of their peers for more than 6 months also, then this can be a social phobia, social anxiety disorder, and needs intervention. So this is more commonly seen in school refusal or poor scholastic performances, that is the poor school performances in children. Now, juvenile obsessive compulsive disorders, I was very flabbergasted when I got to know that a child could suffer from obsessive compulsive disorder, because it was very new to me back then, because I thought this was something for the learned people or the grown adults, but I never knew that the child could also suffer from this. So this can be very time consuming condition. The child is constantly washing, and even in the washroom taking part, so your dental appointments are very slow. And the children can be categorized in 4 categories with this condition. That is your cleaning and contamination category. The child who's suffering is under 4 categories. So cleaning and contamination, who's germophobes, fear of germs, then frequency or ordering or sequencing the order. So that is another condition where and then you are obsessed with your forbidden thoughts or taboo thoughts. So those thoughts come into play, and then impulsations. So these are the 4 conditions which can actually compile and make you an obsessive compulsive disorder afflicted. So I happen to see this child, girl child, again from Tamil Nadu, who is covering her nose constantly, just because she was afraid of the germs. People talking about, of course, now it's Corona and COVID time, this looks very normal. But back then, 10 years back, this was very abnormal from a child who's below 5 years, and, not removing the handkerchief from herself, so much so that her parents, her mother had to separate, suffer from her in-laws on those the temple. They thought the child was affected, since it was a girl child, and the child was affected with some witchcrafts and those kind of uh, whatever superstitious beliefs were undergone, and that the mother and the child had to flew to Bangalore and get admitted into NIMHANS to escape the trauma. So that is one thing. And then in dental operatory, the child would expect you to follow few mannerisms, few rituals, few sequences that the child is very scared of, touching anything, even touching the feet down the dental chair. So because of the germophobic things, uh, yeah, so as such, obsessive compulsive disorder is known to all otherwise. Now, coming on to the condition pertaining to the dentistry, so this you have the compulsive toothbrushing habit, because this can be rectified or tamed to a child by showing a disclosing agent, wherein the child can be shown, the teeth are clean, definitely, so you can stop doing. So the child can brush to an extent as many as 100 times, so much so that you see abrasions, erosions into the child. Um, so many dental problems can arise. So the body focused repetitive behavior umbrella, so this is basically very similar to the stereotypic behavior. This is again a specified obsessive compulsive disorder which is body focused. So they are injuring to the body, but it is very different from the self injurious or the masochistic habits, when an underlying organic disease is available, like you have congenital insensitivity to SIPA or Lesch-Nyhan syndrome, but this is independent of any organic disease. So this is a complete behavior disorder, wherein cheek keratosis, as per dentistry, is concerned. So this basically anxiety and impulsive compulsive disorder. These are the examples. You have borsicatio baccarum, wherein you constant chronic cheek biting. Then leviarium is happening. So you're giving lip bumper to these children. Linguarum, so here you're initiating talk therapy or singing therapy. Dermatolomania, wherein the child is pulling the skin, scabs, pimples. Lip pulling is happening. Onchynophagia is happening. Then you have trichophagia, where the child swallows the hair, rhinotelexomania, picking the nose, and so many other body, focused disorders are encountered in these children. So you need to intervene with the appliances, as well as the cognitive behavioral therapy works wonders in these cases. Moving on to the selective mutism, this is exclusive to the children, and this is actually was termed as aphasia voluntaria back in 77, and termed again the change happened as elective mutism. Now they call it as selective mutism, and this is very rare, where the child has the ability to speak but will not speak because of the social settings. Because the anxiety, so this is again an anxiety disorder which needs to be attended, and you need to take the child into confidence, as the child could be afflicted with social phobia here. Now, so we did speak about the child's characteristics, the parenting styles. Now, moving on to the third category, which can affect our child's behavior, that is the environmental, the ecological concept. If you remember the backslide of the transformational developmental behavior model, which I had spoken. So, coming on to the ecology, this is the media influence, that is the electronic screen syndrome, digital toxicity, like Mr. Sunil said, in the pandemic, it's becoming more. So you have the screen dependency disorder. So any child below 2 years should not be exposed to the screen for less than 1 hour. Anything more than 1 hour is detrimental to the child of age 2 years. So child between 2 to 5 years can have a period of 1 hour exposure per day. But otherwise, the child's disruption in the mental wiring can happen, leading to the neurodevelopmental disorders in these children. So another environmental characteristics of the media influences your eating habits. Anorexia nervosa, where the child doesn't want to eat, thinking about how thin how fat they are. Bulimia, binging on the food, excessive food, because of course, non-edible food stuff eating. So these are basically related to the parenting style. Again, if I mentioned negligent parenting or parenting style or the emotionally detached parenting, it's not that I am constantly accusing or trying to blame the parents. It's just that we need to understand the combination, the reason behind the behavior of this child. So as clinicians, we need to face the truth. We need to work as a combo package on the parent as well as the child. So if you're working alone on the child, helping out the child is not working. So we need to work parallelly along with the parents. So we need to change their parenting style. Likewise, work on the child's dental ailment. So of course, these children are afflicted with abrasions, erosions, bruxism behaviors, orthorexias, wherein extremely healthy food habits, crazy. So that kind of habit is orthorexia. Then you have bigorexia, wherein the child wants to develop muscles. So these are all media influences. So one example or one experiment which I would want to mention to explain how your media can influence the child, for increasing the criminals or violences or any other sexual behavior, inappropriate sexual behaviors in the child. So one experiment back then was conducted by Albert Bandura, which is social learning or observational learning theory. Of course, we do use this in our dental operatory as modeling theory, or Now, modeling theory is very different from what is being told here as social bandura. Most of the people get confused. In modeling theory, which we use in pediatric dentists, the child is modeled by a familiar person. And the person or the child who's respected by this particular patient. So it can be a teacher, mother, or the elder sibling whom the child respects. If the child dislikes the elder sibling, then it is not advisable to show them as a model. So that is very important. Now, these two things should be kept in mind. So modeling, when Bandura had spoken about it, of course, it did help eventually to develop a modeling behavior guidance therapy in pediatric dentistry. But the idea here was to show the emotional impact it could happen, the media could allow. So the experiment basically shows, 24 kids, 12 boys, 12 girls, wherein again six of each were segregated and shown a video where the adult is shown the doll with a hammer hurting the doll. So immediately the children imitated, and there are few children who do not imitate it, anticipating the consequences after it. So those are the championship performers, and these are the punishable performers. So here the modeling happened, arousal of the negative impact happened. So this experiment did come under debate, because it was considered unethical of the impact psychological trauma it would lead. But this is an example that your environment or your social media influence can impact on the child. So this particular experiment is only mentioned here only to show the impact it can have on few children who are not very, this is more frequent in boys. So these boys are basically hitting when they sleep next to the sibling in the night. If they see a media violence or any Xbox or your violent video game, they tend to hit the sibling beside sleeping. So this has to be kept in mind. So you see a modeling wherein the child is being shown a higher authority or familiar environment, unlike the Bobo doll syndrome by the Bandura, wherein this is an unfamiliar, and the child and the subjects and the experimenter were not in direct contact. It was an audio visual this one, and most of the videos have been available on the Google for further details. Now, coming to sibling rivalry, as mentioned in the previous slide, now this is wherein the parents will have a different parenting style for different kids. So this can be initiated. Also, this can be seen in a disabled sibling, or if it is a gifted prodigy or a gifted sibling. So, sibling syndrome is something wherein the normal child or the neurotypical child is completely neglected, outcasted, and not involved into the environment. So, because of the parental culture or the cultural environment in India, which we develop, we keep the secrecy, avoiding avoiding the children to involve, or let them know that their other sibling is being afflicted with so and so this one. So the child thinks out of place and starts feeling neglected. So that is when this rivalry approaches. Sometimes there are positive outcomes if the parents involve these siblings. The positive outcome is that the child becomes more empathizes, the altruism is increased, and they become socially responsible, so much that they become a sandwich generation, that they can look after their old parents, their kids, as well as a special needs sibling. So it depends on how the parents or the environment tackles this situation. So you need to involve these not affected kids into the the procedure or the happenings of the family. Now, moving on to another disorder, which is again from the ecological side, gender identity disorder of childhood. So here I did have this case again in one of the eastern part of the city. I did have a 5-year-old child, but dressed up like a boy, talking like a boy, and also was getting offended if I refer this child to as a girl. So this was very difficult for me, because I was losing cooperation each time I would refer to her as a girl. And then I wondered, why was this being encouraged by the parents and not rather discouraged as early at this age? But even to my surprise, even the teachers joined the uh, joined the fun for the kids, thinking it's funny. But then the child was seeming to be very serious and almost refusing dental treatment if I was referring by mistake even as a boy. So this is something which we need to encounter. So we would, for time being, we do, I did succumb to the child, and because I wanted to finish the treatment. But later I took the parents into confidence, and I told them it's not a matter of timely or temporary. This needs attention. So you need to go to a particular authority or this healthcare professional to attend to this condition for the well-being of the child. So this is one condition. So behavior rating scales, of course, they do not attend to the psychopathology or the adaptive behavioral deficits of a child. So you need to move on to something which gives justice to your, the psychopathology, underlying psychopathology or developmental adaptive behavioral tactics. So you go to the MCHAT for the autism, that is modified checklist. Um, Autism tool for the toddlers. Then screening, this is all available on Google. So these screening tools for the parents as well as the kids. So here the advantage for the clinician is that you get the response from the parent as well as the child. There is yes and no, there is a switch on switch off response from the parents and the child. So you get a response behavior rather than you categorizing or you coming to the inference or judgment of the particular condition of a child. So this gives a lot of scope for open communication. So this is scared is screen for child anxiety related disorder, very handy at the dental operatory. If we cannot, then we can always refer them to the psychotherapists for the analysis, taking of course the confidence into the parents. So functional behavior and analysis is very important and very handy when you want to analyze a challenging behavior in a child, because you need to understand the antecedent, the behavior and the consequence. So what led to this kind of behavior? That antecedent is the prior triggering factors, the environmental factors, the situation, or the particular person. So those are all the antecedents which led to a particular behavior in a child, and then the consequences. So how was these consequences? How was this child dealt later? Whether it was reinforced, whether it was negatively punished, or reinforced differentially. So this all ultimately helps us in behaviorally managing or behaviorally supporting or guiding the child. So this is a ABC of FBA, very popular in an individual subspecialty in itself, and it could be spoken on volumes. So I'm just giving a brief idea on it. So of course we do know about the bad and good reinforces. So focus on good behavior, look at the assets of a child, catch them being good, ignore all the bad things. Forewarned is forearmed. So if you're taking a thorough parental interviewing, you're definitely prepared well to deal with the condition. Though you give the pull out me time, running commentary is very important. Parallel talking constantly is very important to be in sync or tuned in with the child. So replacement of behavior, replacing the inappropriate behavior with an appropriate behavior works wonders. So I did mention about the reinforcement, extension, differential, and punishment. Of course, there is a gadget which has come as motive active. So it gives a contingent time, the play time for the dentist as well as the child. So this comes as wristwatches, or you can keep it as an alarm. So this can be sent even to the schools and special needs, and the child gets that me time in between. Then that's like a positive reinforcer. Even at the dental operatory, it's handy. So you can have this motive aid at your operatory. So not fixing the child, but we're fixing the child's skill deficits. So we're intervening behavior which is not appropriate. We are guiding the behavior which can become appropriate, and support the behavior which is gradually becoming appropriate eventually. So we are fixing the child's skill deficits. So engagement of a particular behavior or from the child is only increases when we reinforce this behavior. The behavior which does not work, the child, it becomes extinct or extension. So the social reinforcers like hugging, kissing, all those, and the activity like allowing them playtime or giving them their favorite, cartoon time, balloons, gifts. Those are all activity oriented, and so verbal appreciation, constant verbal appreciation is sought by these children, because everywhere they keep getting discouraged. So that works in our favor as clinicians. So before conclusion, I would say that every day in 100 small ways, the children are asking us, do you see me? Do you hear me? Do I matter? So we need to understand that, the children are trying to give us some kind of cues, though they're non-verbal, they're, non aimed gazes or stares, the silent whispers are talking to us in a matter. So we need to look beyond, the behavior of the child and understand the child's, the difficulties, and their behavior often reflects our response. So these are the invisible illnesses. So never treat a stranger as per pediatric dentistry. So you need to understand the parent, the child in and out. So you're not treating a stranger. So you need to understand the whole family, avoid cattle calls. You have to go in the operatory, give an individual acknowledgement to the parent, so that you're happy and glad to see them. Don't give a cattle call to the parent. Alpha commands, because these patients are very impatient. So of course you cannot give long instructions. You need to be brisk, short instructions, soft instructions, shorten appointments, and of course mouth is not divorced from the other systems of the body. So you need to see the not just the immediate task of treating the particular tooth, but also you need to see the person behind this patient. So love is not a behavior management technique, but then it works wonders, of course. So this is an acknowledgement to the clinical director of the clinic which I practice in. And here, before thanking the people, with so many seminars and webinars with the pandemic, I could see some attendees did take part into the presentation. So I'm glad, because this is little out of the context topic, not very dental oriented, but I'm very glad. And I do acknowledge all your presence and thank you. And definitely, you know, uniqueness or the difference is something which is unique to human. So you need to accept every individual, and these differences make us united as humanity as a whole. So you need to accept every individual as a whole. Yeah. Thank you, Mr. Sunil.
Thank you, madam. It was awesome. I think you have dealt with the topic so comprehensively, not only talking about the different parenting styles, but also the 9 temperaments of a child, and also the challenges which routinely the dentists will face at the dental chair side. So I think that was awesome. There have been a lot of encomiums. Everybody are saying that it was fantastic, the talk. There are 1 or 2 questions, ma'am, so I will just field them to you.
Yes,
Dr. Rekha Shetty is absolutely in awe of your talk, and she was just recollecting that one of the child, when it was taken to the dentist was a little harsh. In fact, slapped the child since it was non-cooperative. So probably a lot of conditioning is required. What's your reaction to such a situation,
yeah.
ma'am?
So like I said, we cannot change or fight the existing system, sir. I'm quoting Buckminster again. So we're just creating a model and making the previous dentist's practice obsolete. We can
Yes.
just set example. We can create a kind of activism, basically. I mean, this is something
Yes.
which I cannot comment.
Correct. New thoughts, new styles of practicing
Yes,
should come in.
corporal punishment, either in parenting, teaching, or in clinical practice, is outdated. It's not very welcome. Being assertive, being disciplined, yes, is welcome. So, assertive voice control can always manage the whole show.
Yeah, the tone of the speech or the
Yes.
talk itself can convey a lot of meaning. So, Dr. Rekha madam also asks, generally speaking, how to prepare the child? How should the parents prepare the child before taking the child to the dentist for
So
the
you
first
need
time?
to give visual images. The cartoons have come, a lot of exposure in the cartoons. There's also, I think, a game in the videos wherein the child plays so much that it can actually handle the suction tips in the video games. I am not
Ah,
able to recollect the video games names, but those are the kind of things which can prepare the child, and the child becomes less fearful and more
yes.
accommodative.
Very nice, ma'am. And Dr. Millen wants to know, generally speaking, of course, you have dealt with it elaborately, but which are your favorite theories of child psychology, which you feel are important for differently abled child? Like if Dr. Millen knows that he is going to get a differently abled child,
Yeah,
what should run in his mind?
I don't know. I feel Skinner's operant, Pavlov's classical. I mean, it's no one school of thought, sir. Definitely, Paget always stands first.
Ah,
All-time favorite for us. Like I spoke in the previous seminar also about Mr. Paget. But operant conditioning, stimulus response is similar to the functional analysis of behavior. Antecedent behavior and consequences, basically your Skinner's operant conditioning, wherein stimulus response and the behavior happens. So it is a combination. I think it has to be tailored to particular child, particular condition, and also our feasibility. It cannot be like this. But like I said, Paget stands first.
okay. So generally, how much extra time would be required for a dentist to deal with the differently abled child? Like if he has to plan procedure, bearing in mind he is a differently abled child,
So
What should
definitely 30
we spend?
minutes are a must, sir, because you need to
Yeah.
understand the parent and the child, and consecutively you are reducing your time of interview with the parent and child. So
So
again, it depends
maybe,
on the skills of the clinician, how early it can catch.
okay.
I mean, you as a pediatric dentist, you look at the tooth and you just measure with the eyes and you know which crown has to fit. So I think
Yes.
over a period, at least for me, it comes with is, yeah, I can actually confide into parents quick, and I can tell if the child is on spectrum, or I can just whisper ki, acha. I mean, if you're using terminologies like poor scholastic performance, school refusal behavior, the terms which are used by therapists or psychiatrists, then the parent understands that the dentist is in sync. The dentist definitely knows that I cannot hide this condition. So it's easy for
Ah,
me to, so, I'm very happy to see the eye contact of your child or the pointing of your child. But I have
hmm,
actually suspected something, and that is when I make it very obvious that I have noticed something. So that
hmm.
actually gives a hint to the parent, and the parent easily opens up. So I think,
Ah, that's very interesting. I think that's a brilliant hint which other doctors are
yes,
catching on.
yeah.
And there is a smiley for you from Dr. Milind Rajan. And Dr. Anita wants to know that these days delayed eruption in children is quite common.
Yes.
So, what do you feel? Should any investigation be done?
The sensory seeking, the proprioception can be initiated. The regular delayed, uh, uh, procedures what you do, like massaging with the finger toothbrush on the gum pads. So I
Okay.
don't know what is the reason for delayed eruption,
Yes.
like as a whole. Generally,
Correct.
I can tell a few things, but that particular child, why it is delayed erupting, we need to
Yeah.
again customize or tailor the child's family and
Any
child.
particular reason, in your opinion, is number one in your experience?
Dietary habits, lifestyle,
Dietary.
because we
Okay.
are not we are moving completely to the refined habits. We're not going into the crunchy foods. Like
Yes.
our days, we used to bite guavas, and
Yes.
now even the guavas and apples are sliced, even mangoes are sliced. So those kind of
They
seekers,
want to
sensory
remove the
seeking.
skin also of the
Yeah, I
fruits.
know. So those things are the lifestyle
So they
basically.
all have a impact, right?
Yeah.
Madam, one last question. I think you are tired, but still you must be energized because Kavita has just commented very thought-provoking presentation.
Oh,
So
thank
all
you.
these appreciations should energize you.
I
Jyoti has
hope I
also
did
said
make a difference, at least in my fellow colleagues, to take that extra effort. I know we do
yes.
not get anything, but this can be highly rewarding from a patient, and you do have a peaceful sleep if you are doing that extra. When the parents come and acknowledge you, definitely
Hmm.
we're making a difference. So I just want to awake. This was just like I told, it's a retrospective or a reflective presentation which I had given long back. This was of course a reformed form. I
Yes.
just want my colleagues or the fellow fraternity, pediatric dentist in particular, to step ahead, move,
Yes.
put a little
In
extra
fact,
effort.
Jyoti has said that it's a very atypical topic and excellent lecture.
Thank
And
you.
one more last question.
Yes.
Any special dental chair or any dental appliances or attachments that a dentist should invest on if he is going to get into these sort of pediatric practices?
So, actually, being in a country like ours, developing country with limited resources, we need to accommodate ourselves. Of course, with advancements, we can afford. Depends, and because in a country like ours, with so much investment, we cannot expect the parents to combat your expenses. So, of course, that frustrates us again because we're not able to get the returns appropriately. So, I think
Yes.
it's basically your inherent skills which you need to develop to accommodate in any situation given. So public
Okay.
health or preventive dentistry, I mean, I think that's the
So
things.
there's no need to invest much on the machinery or the
No,
dental
no,
equipment,
no,
but
no.
it's the skills and the
Yes,
attitude of the doctor. I
yes,
mean, it's going to be very challenging managing these sort of kids. And yes, there are encomiums again flowing in. And I think we can close this session with a very interesting remark from Dr. Rekha Shetty, who says, indeed, a very good presentation done with heart. So it's come
thank you,
straight from your heart, she says. Thank you so much. You have given so much
thank
energy
you,
to
thank you,
the dental fraternity today. And I deem it a great honor that Group Pharma has partnered with you, ma'am. Thank you so
thank you.
much. Continue to have confidence with us. I
Yes,
take your permission, ma'am. Can I
yes,
please
sir.
close
Please,
the webinar?
yes,
Okay.
please.
Thank you, Dr.
Thank you, thank
Milind
you,
Rajan. He has also given you one more cheer. Thank
yes,
you very
sir.
much.
Thank you.
Thank you.